Welcome, everyone. I'm Dr. Kaylina Eggets-Martins, and I just want to thank you all for joining us today. We're really pleased to have speakers represented from around the world. So we have speakers today from Brazil, India, the Netherlands, Belgium, Germany, Switzerland, USA, and Canada. And really, this event is meant to showcase work from our ECR community, which is really the future of freezing of gate research. And we really also want to bridge the gap between our in-person conferences to make sure that we can still facilitate sort of a growth in our community and exchange amongst our ECRs. So know that you're amongst a community of warm and friendly faces for all of our ECRs who are presenting today, and we're really excited to see your work. The format is 8 minutes for each presentation with 2 minutes of questions. Please put your questions in the chat and the chair can ask them if there is time. Otherwise, the presenters are free to answer the questions after their talk. Okay, well, to get started, it's my pleasure to introduce the chair of this session, who is, of course, known by all for her work in freezing, as well as she's a strong advocate for ECRs. Please welcome Dr. Newbor.
Thank you very much, Kalina. And it's also from my side, I would like to give everybody a warm welcome to this next generation session. I'm really pleased to chair this session, which will highlight the work of emerging investigators in our field. So I expect a lot of fresh perspective, innovation, and energy. As said, we will have 5 short presentations of 8 minutes. And what I will do is I'll put up my hand so that you know at 7 minutes that you only have 1 minute left. And then we'll see how we get to the end and whether there is time for questions. So let's begin by welcoming our first speaker, and that is Amey Desai. He is an engineer from Mumbai University and also the University Hospital there. So go ahead, Amey.
Thank you all. My name is Amey Desai. It's a pleasure to be here amongst veteran researchers in FOG and having the opportunity to present our research. Right. So today I want to discuss personalized factors that affect technological solutions for mobility. To give you a little bit of background, a few years ago, I had developed a wearable device that helps to reduce freezing of gait in individuals with Parkinson's. Upon validation, we noticed a small cohort of relatively, well-grouped individuals who would not respond to such a treatment. So today I'm going to walk you through the intervention, through the validation that supported the intervention, and how and why we feel there are certain groups which may not respond to this type of treatment, which might open up interesting perspectives for precision medicine. To begin with, we developed what is called the walk device. The walk device is a non-invasive wearable neuromodulatory device which operates on the basis of vibration. It provides vibration to the muscle tendon junctions of the hamstrings and the quadricep muscles in an attempt to improve freezing of gait. Primarily, we think that by providing such a stimulation in a cadence-linked manner, the device improves proprioceptive inputs that may, as a secondary effect, help improve the effect of the reduced descending drive seen in Parkinson's disease. A quick example of what the pilot studies look like. So here you have an individual suffering from freezing of gait in a narrow space, a fairly well-known phenomenon. Upon turning on the device, on the right side, you can see they're able to cleanly step through this. Following this pilot result, we proceeded to perform a validation study. This was a sham-controlled 16-session study carried out over 6 weeks for each participant, where a group of 24 intervention arm individuals were given the device, and the remaining 16 participants were given a sham device, which looked and sounded exactly the same, but did not deliver the stimulus at all. We used a modification of the Ziegler scale to measure efficacy, and the devices were given to these individuals to use in their homes alongside motor training for both of the groups. The groups were evenly matched in age, sex, and disease duration. and their Horn staging. And they were measured in somewhat of this manner. So we measured across 6 tasks done in the single as well as dual task format. So 6 meter straight walks, turn on the spot, navigating a cluttered area, and exiting through a door, all done in the reverse order, also with an arithmetic dual task. And they were scored similar to the Ziegler scale, where severe FOG of akinesia more than 30 seconds was scored 3, which was the maximum. Akinesia resolving in less than 30 seconds was scored as 2. And minor festination or shuffling was scored as 1, with no freezing or any gait issues being scored as 0. The intervention arm showed a significant improvement, whereas the sham group did not show a significant improvement. And to our surprise, not only were turning and narrow space navigation improved, the dual tasks were also improved. Broadly, we were able to see an improvement from baseline to this final session, not only with the device, but also a baseline improvement without the device. So each assessment session was carried out first without the device and then with the device. Now, so this is the history of the device. This is why we carried out the part I'm presenting today. So we had 75% of individuals who responded to the device, having shown a difference better than the minimum clinically important difference. But the group of 25% non-responders were showing some patterns. We felt that they had distinct subgroups, which might, be able to predict response or non-response to such a stimulation. And that is the work that I would like to present today. So upon validation, consecutive patients who appeared in our partner hospitals were considered, and we took 16 non-responders and matched them with a similar group of 19 responders from subsequent data, and measured them in much the same way. Initial response to the device after 10 minutes of training with it. And for 14 of those patients, we also had data for up to 8 months follow-on, where they were using this device at their homes. Similar to the validation study, the improvements were seen in turning, narrow space navigation, dual tasking, and individuals seem to respond in majority of the FOG inducing tasks. However, severe rigidity, severe balance impairment, and pain, factors that also affect initial usage of the device, seem to be limiting factors. Now, just before I am able to show you the profiles, I will also discuss a little bit about long-term responders. So for the patients for whom we had longer-term data up to 8 months, while the responders were showed sustained response, there were a few initial non-responders who seemed to actually show a response after a long delay of at least 2 months. And 2 non-responders had persistent scores afterwards. There were no responders who later turned to non-responders in this study as well. Point I would like to just clarify, since it is not written here. Yes. So broadly, the green line on the graph on the right shows the trajectory of the late responders, where you see, even though this is a small number, you see there's a strange pattern of the symptoms worsening before they improve, which is similar to the pattern seen in responders. So we wanted to investigate, and upon a demographic data and other analysis, we realized that responders actually seem to have longer disease duration, whereas non-responders or late responders seem to have increased burden of non-motor symptoms, as well as autonomic symptoms earlier in the course of the disease. As such, the division or the distinction between the responders and non-responders is quite clear, and future research will focus on understanding why this is happening, and how do we predict this much earlier in the course of disease and provide precise treatments. This applies to a significant number of devices that are vibration based. We believe that these results might also extend to electrical stimulators or modified FES devices that patients might use. And this is important in the context of providing therapy at home, because response versus not response will actually lead to changes in adherence as well for other devices. I thank you for your time and would love to take questions.
Well, thank you very much, Ame. And you have been within time. There are no questions at the moment in the chat, but I will ask you a question. First of all, the mechanism of your device, how it is different from other devices. What I understood is that it is a mechanism based on vibration, and that vibration, is it a continuous vibration, or is it a vibration that goes in pockets?
It goes in pockets, so it is cadence linked. For
Right.
this study, we measured the natural gait of the person and matched the cadence of it in a
Okay.
cue-like format. We
Yeah.
do have separate data where this is self-initiated as well. So it would either stimulate in the swing phase or in the stance phase, based
Right.
on what the patient feels.
Okay. And then continuing from that, could you also explain then, because you gave it a very neurophysiological, mechanistic background first. You said you wanted to adjust proprioception, and you wanted to sort of start to think, you were thinking about spinal neural mechanisms of this particular vibration. So how do you think it is different from an cueing device, an ordinary cueing device, an auditory cues, because it is giving a rhythmic stimulation as well?
Yes. So the arrhythmic stimulation is one of the modes, and in that mode, it does resemble a cueing device.
Hmm.
However, there are two differences here. One is there are other modes, such as those that stimulate only in the swing phase, or only in the stance phase, or only in a particular part of the of either of these phases, which have also been equally effective in our data. The second is that with queuing devices, we have so far not seen a uh, a sustained baseline improvement as we have seen with this device. Of course, there are only 40 patients in that study, so there needs to be more work done. But it is encouraging to see that the baseline is also improved without the use of the device, which is something that generally I have not seen in the queuing devices, although I am open to. Uh,
Yeah. It would be a nice sham condition, I think, in a next study. But we don't have time to go into that any further. But thank you very much for your presentation. Um, and perhaps if people now have questions for you, they can put it in the chat a priori. No,
Yeah,
post hoc, I mean, sorry. Um,
it is.
yeah.
I will say. Thank you. I will say it's actually
In,
the Q and A section. So the chat
oh,
is
right.
disabled, but the
Perfect.
Q and A is the one to use. And there are
Okay.
some really interesting questions in here. Really interesting work.
The next speaker is Sindel Albers.
Wonder. Excellent.
Yes.
Then Sendel, you are ready to go, and I will give you control of the thing.
Go ahead, Sindel.
Thank you, Alice. So my name is Sindel Albers, and today I want to tell you something about how cognitive and motor capacity determine cueing efficacy in Parkinson's disease, and show you some of the first results of the UNITE PD study. So, as you all know, gait impairment is one of the most common and most disabling symptoms in PD, whether it's present continuously or occurs as freezing of gait. And a key part of rehabilitation is the use of cueing strategies, such as external cueing, like walking on the beat of a metronome, or internal cueing, like counting while walking. And for some patients, these strategies can substantially improve their gait, but we also know that the strategies do not work equally well for everyone. And despite the past years of research, we do not fully understand why that is and what the possible underlying mechanisms are. So for that reason, the UNITE PD consortium was initiated. It's an international multi-center consortium in which we combine efforts to address these knowledge gaps that still exist around cueing strategies. And today I want to show you a little bit about our first two joint objectives. First, that is what patient characteristics influence cueing efficacy. And second, what is the long-term effect of cueing after 6 months? So in our study, we defined the response to cueing with the use of an objective gait assessment. And in that assessment, participants first walk in the uncued condition. Sorry, the slide now went further than I wanted. But participants first walk for 2 minutes at a comfortable pace without cues, followed by walking trials with external cueing and internal cueing. And during external cueing, participants step to the beat of a metronome that's set to their preferred cadence. And during internal cueing, they count 1, 2, 3, 4 in their head and match their steps to those counts. And our primary outcome is the cueing efficacy, and that is defined as the difference in the stride time variability between the cued and the uncued condition. And then for our first objective, we then relate this primary outcome to a broad range of motor, cognitive, and affective patient characteristics. So in our study, we have included 277 individuals with Parkinson's disease and have self-reported gait impairment. And when looking at the MoCA, UPDRS 3 and the mini best, we saw that most of our participants were in the mild to moderate stage of the disease. And in our cohort, we had seen 111 participants that experienced freezing of gait. And a first key finding of our analysis was the large influence of uncued stride time variability. Because here in these graphs, you can see for both external and internal cueing on the y-axis, the respective cueing efficacy, and on the x-axis, the uncued stride time variability. And while it is expected that someone with a larger baseline impairment also has more room for improvement, it is also very interesting because it shows us that someone that has substantial gait impairment can still improve their gait when using the cueing strategies. And then besides the uncued stride time variability, we also assessed the further patient characteristics. And here you can see a whole list of the variables that were significant in the univariable analysis. And underlined and in bold are the variables that were retained in the multivariable model. So for external cueing on the left, you can see these 4 variables were associated with better cueing response. So a higher score in these variables were linked to better external cueing response. And for internal cueing, we saw partially similar effects, but instead of the MoCA that we've seen for external cueing, we saw for internal cueing a higher digit span forward and a higher Parkinson anxiety scale score that was related to better internal cueing response. And as a next step, we wanted to evaluate how robust the variable selection was for our multivariable model. And to do this, we used bootstrapping and examined how often variables were selected across the resampled data sets. And what we observed was that the exact variables included in the model differed for the different bootstrap samples. So for example, in the first bootstrap sample, these were selected, whereas in the second, these were selected. And after 1,000 bootstraps, it became clear that the relative contribution of individual measures was not entirely stable. But when we looked beyond the specific variables themselves, a much more consistent pattern became clear. Because even though different measures were being selected, they all seem to capture the same underlying clinical domain. For example, here almost every bootstrap model included at least one variable that related to higher or better motor performance, and the same was seen for the cognitive domain. So this suggested that the broader latent domains may better explain the differences in the cueing efficacy, leading us to the next step in our analysis, which was principal access factoring, because we wanted to identify the possible underlying constructs that might be present that were described by these clinical measures. So the results of this factor analysis for external cueing, we indeed identified a clear motor and cognitive performance factor. And a higher performance in these factors were associated with better cueing efficacy. And for internal cueing, we saw again a similar pattern, but now additionally also once more higher anxiety-related symptoms were associated. And there was an interesting 3-way interaction that we noticed. So between uncued stride time variability, motor performance, and cognitive performance. And this possibly indicated a partially compensatory mechanism in which cognition and motor performance may function as interchangeable moderators of the cueing efficacy. And today I also want to very shortly present some preliminary results of our second objective, which was the long-term effect of queuing. So in our study, responders to external queuing were followed for 6 months, and we instructed them to use queuing strategies as much as possible in their daily life. And for this, we installed a custom-made queue app on their phone. And then after 6 months, we reassessed the effect of queuing. And this was again defined as the difference between the stride time variability in the queued condition and the stride time variability in the unqueued condition. And here you first see the stride time variability of the queued condition. And you can see there's not much difference between the T0 and the T1 assessment. But then when we took a look at the unqueued stride time variability, we saw something interesting happening. And we saw that the participants that were instructed to use the queues as much as possible in their daily life, that they showed a clear reduction in the unqueued stride time variability. And this suggests a possible carryover effect where training with queues may also even improve natural gait. But of course, these findings are still very preliminary and require further analysis before we can draw any definite conclusions. So today, to conclude, I'm proud to present these first results of the UNIPD study, and they show that both cognitive and motor capacity determine queuing efficacy in Parkinson's disease, while they also point towards some possible longer-term benefits as well. And we look forward to sharing more in the upcoming papers, and I would like to thank you all for your attention and sincerely thank all our consortium partners for making this work possible.
Great. Thank you for keeping so to time, Sindel, and thank you for your interesting presentation. Yes, I have a question because I think the most intriguing finding is that a higher anxiety led to better results of internal queuing. So do you have any explanation of that intriguing finding?
Well, the idea that we had now is that possibly the already heightened attentional control that people experience with more anxiety, that this attention is now more focused to the gait itself and not to the more negative anxiety-related thoughts. So they have more internal attentional control already. And maybe that then for those people focusing on counts, they can use that heightened activity that is seen in the anxiety-related symptoms and adapt that in a more positive way towards gait.
Yeah, because usually it is maladaptive anxiety,
Yeah.
but yes, it is a possible explanation. Another thing that I noticed is you had quite a few freezers, about 40% of freezers in your population. And it wasn't a predictor as far as I saw on your slides.
No.
Or was I wrong? And if you have to think about freezers and non-freezers, which type of queuing, internal, external, would you prefer for the population of freezers, knowing the predictors that were at play?
Well, I think, indeed, it wasn't significant for
Right.
the analysis that we did, but it was borderline significant. So there was some trend to be seen. And we saw that mostly for external queuing. And I think maybe regarding that, someone who experiences freezing is already a lot in their head. And then sometimes it can help that something from the outside, so an auditory cue, can help them focus on something else than their problems that they're experiencing at that moment. That might be better to more beneficial for external queuing than internal queuing.
Right.
But it would be very interesting to do some sort of sub-analysis on that and see if there's anything else. Yeah.
Okay, thank you very much. Very interesting. I guess, Lucas, that we go to the third presentation, and that is from Philip Knocke from the University of Tübingen in Germany.
Thank you very much for the great introduction. I want to speak about cognitive and emotional determinants of subthalamic oscillations during freezing of gait, which is a sort of a direct continuation from the previous talk where I also raised some questions about anxiety as well. And so I want to dive directly into my work, and so I want to spend some time on explaining our rationale behind our project here. And as many of you know, there are different models that sort of help explain the pathophysiological groundwork of freezing of gait. And so at this stage, I want to touch on one specific model, which is the executive dysfunction model. And so this is where freezing results from a specific decoupling between the cognitive areas in the frontal lobe and the basal ganglia. And so these are usually, as we explained in the previous talk, these are areas in the brain that are being heavily recruited to compensate for a lack of gait automaticity, which then can lead to freezing during tasking or, for example, during cognitive demanding tasks. And many of these pathophysiological assumptions were shown to hold true in previous work. For example, Kaylina Eggert-Martins from Waterloo in Canada showed in previous work that there's a sort of a decrease in functional connectivity during freezing between the cognitive and the motor areas compared to the striatum, indicated in gray, for example, whereas we did find some increases in functional activity in the limbic structures and the striatum. And this is very interesting because it does reflect what scientists had found out a few years earlier, showing that decreased executive function, as measured by the trail making test, set shifting test, for example, significantly related to greater freezing episodes and overall time spent freezing. And at the same time, great anxiety was also measured using the hospital anxiety and depression scale, and that also related significantly to Parkinson's disease subjects with freezing of gait. And last but not least, I think some of these aspects, so affective versus cognitive control, they also seem to interact with each other, meaning that great anxiety also leads to greater executive dysfunction. I'm going to do a slight sort of methodological cut here. So as you know, over the past few years, we've now acquired the chance to sort of directly measure the electrical activity of freely mobile Parkinson's disease patients using deep brain stimulation and electrodes, which can directly measure the activity in the subthalamic nucleus, which is part of the basal ganglia. And so correlating the LFP activity, local field potential activity, with non-motor symptoms, such as anxiety, for example, or neuropsychiatric side effects in Parkinson's disease patients, have led to two major articles being published last year and this year. And the reason I'm highlighting this is because next to motor symptoms, we can now detect non-motor symptoms in local field potentials, which finally brings me to the hypothesis and aims of our project. We wanted to investigate the extent to which overall emotional and cognitive symptoms severity sort of correlate with a neuronal oscillatory activity in Parkinson's disease patients during freezing of gait, more specifically during freezing while turning. And so to do this, we asked 13 Parkinson's disease subjects, of which we know they are freezers, to walk up and down a hallway, sort of indicated by the schematic that I draw here. And at the same time, we did record their local field potentials using the Medtronic Percept neurostimulator, and specifically focused our analyses on regular turning versus turning motions with freezing of gait. And we then sort of related the activity, the spectral activity during turning, to the MoCA score, the hospital anxiety and depression scale, and recorded the trail making test and motor severity using the MDS-UPDRS scale. We then sort of assessed statistical significance using linear mixed effects models, where we combined the MoCA score, the HADS-A subscale, the hospital anxiety depression subscale, and also the SDN laterality to see if there are any effects regarding the left or right hemisphere. And also the random intercepts, of course, were noted for each individual subject. These are just the clinical descriptors of Parkinson's disease patients. And so we first compared the spectral profile during freezing and during regular turning between these subjects, and you can notice some differences in the beta band range as well as in the theta band range. Disease duration, MDS, UPDS-3, and the MoCA score, they were fairly sort of similar to other Parkinson's disease cohorts, and we noted some slight variation in the severity of the HADS-A and the HADS-D subscales. And so now after the results, given the sort of the private evidence that we have, which sort of implicates theta oscillations in cognitive and in affective control, we first analyzed theta oscillations and how they might have an effect on the emotional and cognitive parameters during freezing while turning. And so overall, the model that we drew explained about 62% of the variance in LFP theta power, while the fixed effects alone, which is the MoCA score, the HATS-A and HATS-D score, they sort of explain about 26% of the data variance. And for the anxiety score, we noticed a significant positive relationship, such that sort of 1 unit increase in the HATS-A score was related to about a 17% increase in theta power, meaning higher theta power related to higher anxiety. And I want you to keep in mind that the beta coefficients here are relatively small, and that's because of the way the data is being projected here, as we're using log 10 scale for the theta power. For the depression subscale, we noticed no significant relationship. And lastly, for the MoCA scores, the cognitive part, we did find another inverse statistically significant relationship, meaning that 1 unit decrease in the MoCA score related to about a 12% increase in LFP theta power. Again, we found no significant relationship regarding the SDN laterality, meaning that the same effects were shown for the right and the left SDN. And we also didn't find any significant effects using the set shifting score as an additional fixed effect. We then created separate linear effects models to see whether anxiety, depression, or cognitive scores were associated with the theta oscillations during regular unimpaired turning, and again found no significant relationship here. Again, we did the same models for the alpha and the low beta and high beta frequency range, but again found no statistically significant differences. Last but not least, take-home messages, and these are just the brief ones. So basically, we did find that SDN theta power during freezing while turning is positively associated with anxiety, with bilateral effects and more specific to freezing. And we could show that the higher SDN theta power was observed in individuals with greater cognitive impairment and greater anxiety, which is consistent with the conflict sort of related demands via the medial prefrontal cortex SDN hyperdirect pathway. Slightly complicated, but in other words, it does mean that according to the executive dysfunction model that I showed earlier, freezing might represent a failed attempt to compensate for that lack of gait automaticity, which could directly result in decoupling between these cortical areas and the SDN, and hence lead to freezing. And so, as you know, Parkinson's patients, they rely on more cortical control during walking. And so, in other words, high anxiety and low cognition, they might contribute to freezing by shifting or diverting away the attention that they need in order to compensate for gait control. Last but not least, these analyses were specific to freezing while turning and specific to the theta band range and not to the beta band range. And that may be because the beta band may be more specific to motor control, may not sort of directly represent the affective or emotional control during freezing of gait. And with this, I'd like to sort of end my talk. Thank you for your attention. And if you happen to be in Tübingen at one point, please stop by and say hello. Thank you.
Okay, thank you very much, Philip. We only have time for, I think, one question, and by now I can see the chat in the questions in the chat now, which I couldn't in the previous with the previous speaker. So I see here a question from Simon Lewis. He is saying to you, excuse my personal bias, but your data would seem to fit more with the interference rather than the executive dysfunction model.
That's a good question. Well, we didn't really use at this stage interferences. Well, we didn't do serial subtraction tasks for this particular analysis. So this may be a good question when it comes to cognitive control, but I'm not quite sure about how anxiety would sort of fit in this particular model without sort of striking all the other two models that exist to explain freezing. I'm not entirely sure if I can answer this question entirely, but we'll give this a thought.
Okay. Well, thank you. I suggest that you and Simon and also Moranis has posed a question for you in the chat as well, that you continue the conversation there.
Yes.
And then in the meantime, we would like to welcome our fourth speaker, which is Annika Vekjan from the University Medical Center.
My name is Annika Wiekjan, and I'm a medical student at the Department of Neurology at the University Medical Center Hamburg-Eppendorf in Germany. And together with my colleague Alessandro Goberti, I'm working on this project on arousal-related mechanism in gait dysfunction in Parkinson's disease. And today I'd like to share some of our first preliminary findings. So, as a brief background, freezing of gait is increasingly recognized as more than a purely motor problem. Clinically, we know that cognitive, emotional, and attentional processes can have a substantial impact on locomotion in patients with Parkinson's disease. This suggests that gait dysfunction cannot be fully explained by abnormalities within the motor system alone. At the same time, recent advances in sensing-enabled DBS systems allow us to record subthalamic activity during movement. Since SDN beta activity is closely linked to motor network function in Parkinson's disease, these recordings provide direct insights into motor network dynamics during locomotion. To better understand which additional brain system may contribute to locomotion, it is helpful to consider the current proposed gait network. So these clinical observations are consistent with the anatomical architecture of the current proposed gait network illustrated on the right side. At the bottom are the spinal locomotor centers, which generate the actual stepping movement. From the brain to the spinal centers, two descending pathways have been proposed. The pathway on the left, representing a direct projection, and is thought to support more stereotyped aspects of gait. In contrast, the pathway on the right has been termed as an adaptive gait pathway. It involves interaction between the supplementary motor areas, the basal ganglia, the mesencephalic locomotor region, and finally the locus coeruleus. As shown on the left, Aston, Jones, and colleagues demonstrate a close relationship between fluctuations in locus coeruleus activity and the pupil diameter. So this is important because locus coeruleus activity cannot easily be measured directly in humans. Therefore, pupillometry is widely used as a non-invasive proxy of locus coeruleus-related arousal activity. Together, they allow us to study both arousal-related and motor aspects of locomotion at the same time. So our objective was to characterize physiological modulation during locomotor demand in Parkinson's disease. We performed a simultaneous multimodal recording combining pupillometry, STN local field potential, EEG, and EMG in a controlled experimental setup. Participants remained seated in front of a fixed visual target under standardized lighting conditions. To minimize pharmacological and stimulation-related confounds, all recordings were acquired in medication and stim-off condition. To investigate locomotor-related neurodynamics under controlled conditions, participants performed a seated alternating stepping task. Each motor block lasted 90 seconds and consisted of 30 seconds of rest, 30 seconds of stepping, and another 30 seconds of rest repeated 3 times. Our cohort included 19 patients with Parkinson's disease and bilateral STN DBS, of whom 13 were included in the final analysis after quality control. The mean age was 62.6 years, and the time since STN DBS implantation was around about 1 year. To clinically characterize motor symptom severity, we assessed patients using the MDS UPDRS Part 3 and the stim-off condition. So as a first result, we looked at the multimodal signal dynamics across the experimental tasks shown here as a group mean across 13 patients. The dashed vertical lines indicates the transition between rest, stepping, and the subsequent resting phase. Starting with the green signal, leg EMG activity increases clearly during stepping, with the expected rhythmic pattern reflecting the alternating stepping movement, confirming that the motor task was performed as intended. Looking at the orange signal, EEG beta activity also changes clearly across the task, showing the expected movement-related decrease during stepping, followed by an increase after movement. A very similar pattern can be seen in the purple signal, representing dorsal SCN beta activity, with suppression during stepping and a clear beta effect afterwards. And finally, the blue signal showing the pupil dynamics, which also changes clearly across the task with a distinct increase at the onset of stepping, followed by a gradual decline during continued stepping and a further decrease after returning to rest. So overall, we observed clear task-related modulation across all recorded modalities. After looking at the time course data, we performed paired within subject comparison between rest and stepping to quantify these task-related differences. As expected, EMG band power increases significantly during stepping, confirming successful task execution. EEG beta power and SDN beta power both showed significant movement-related decreases, consistent of what we already observed in the time course plot. In contrast, when analyzing pupil activity across the entire 30-second stepping interval, we did not observe a significant task-related effect. This suggests that averaging across the complete task period might not capture the most relevant pupil dynamics. We therefore took a closer look at what happens right at the transition into stepping. Specifically, we compared pupil dilation the first 5 seconds before movement onset with the 5 seconds immediately after movement onset. This revealed a significant increase in pupil dilation after stepping began. We then asked whether this early pupil change was related to subsequent STN activity after stepping. Interestingly, larger pupil dilation at stepping onset were associated with stronger post-stepping STN beta rebounds. Using a repeat measure correlation, we found a strong positive association with an R value of 0.87 and a P value of 0.001. Together, these findings suggest a potential link between arousal-related and motor network dynamics during locomotion. So to conclude, we observed clear task-related modulation across multiple physiological modalities during stepping and Parkinson's disease. Motor, cortical, subthalamic, and pupil-derived signals all showed characteristic changes associated with locomotor demand. Importantly, exploratory analysis revealed that early pupil responses were linked to the magnitude of the subsequent STN beta rebound. Together, these findings suggest that pupil dynamics may provide additional insights into gait-related network mechanism and support the value of combining pupillometry with electrophysiological recordings in Parkinson's disease. So finally, this work opens several interesting directions for future research. First, we plan to investigate dynamics interaction between the recorded signals using time-reserved imaginary coherence analysis. And we also wanted to better understand arousal motor coupling by relating pupil oscillation to STN beta dynamics during locomotor transition. And finally, we are interested in whether pupil-related signals can help explaining inter-individual differences in locomotor network recruitment and whether they may serve as potential markers of freezing-related network dysfunction. These are my references. Thank you very much.
Thank you very much, Annika. I don't see any questions. Oh, yes, there is a question. Simon Lewis asks, were you able to explore the pupillometry with any measures of freezing of gait, given previously published data on the role of NAD pathways?
So if I understand the question right, you ask if we observe freezing in pupil?
Yes, that's right. Yes, do you want me to repeat the question? So if you were able to explore the pupillometry with any measures of freezing of gait?
To be honest, our task was too short to explore freezing because only 30 seconds, we didn't see any freezing during that time.
Right, okay. And there's another question for you. Did you look into comparing stepping-related beta modulation to other motor tasks-related beta modulation patterns?
So these are our first preliminary findings, but it would be a good idea for further ideas to work with it.
Yes. And I have a question as well. Do you interpret the observed coupling that you showed us between pupil dynamics and STN beta activity as reflecting a causal influence of arousal on motor control? Or do you think that these two elements are parallel but not really related?
So could you please repeat the question?
Yes, I can.
In a shorter way. Yeah, thank you.
Yes. Do you interpret the coupling between pupil dynamics and the STN beta activity as reflecting a causal influence of arousal on motor control? Or do you consider them to be parallel processes?
So at the moment, I'm not quite sure if I could answer this question because it's the first preliminary findings, but as we could see, there's some similarities between this both, but it's a part of a next experiment to find this out.
Okay, thank you very much. Then we're already moving to our fifth speaker, which is Claudiane Fukuchi. She is, by the way, from the movie lab from Sao Paulo University, State University in Brazil.
Today, I'm going to present my study entitled Neural and Biomechanics Correlates of Freeze-off Gait in Parkinson's Disease. So step initiation is a complex motor task that involves a transitioning from a stationary standing to a posture to dynamic balance to initiate the movement and move forward. And this task involves both motor and cognitive process that also include the anticipatory posture adjustments, the APAs. And in order to have an effective step initiation, we have to have a good control of body balance that indicates by the APAs. That's what happened. And the center of pressure needs to move lateral and posteriorly in order to control the balance and move the center of the mass of the body to the stance leg, that this allows the body to move forward and initiate the movement. But what happened in individuals with Parkinson's disease? So usually they have these impairments in between this transition from standing posture to initiate the movement. And a key issue is the dissociation between this anticipatory posture adjustment and the step onset. So what's happened in the APA of Parkinson's disease, they have a delay between the time that the APA happened and the first step. So compared to the health controls. And in individuals with freeze-off gait, this is more exacerbated. So the APA duration usually is longer in individuals that present freeze-off gait compared with individuals that do not present in freeze-off gait. Despite the motor impairments, individuals with Parkinson's disease, they also present cognitive deficits, especially in executive functions, such as inhibitory control. In the previous study, they showed that, when a task with conflict resolution was tested, usually individuals with Parkinson's disease, they present a slower walking and also they make more mistakes than health controls. In previous neuroimages studies, they found that during these anticipatory posture adjustments that involve step initiations, involves a high level of cognitive process, especially in the supplementary motor area and the dorsolateral prefrontal cortex. So the supplementary motor areas is involved in preventing the inappropriate steps, while the dorsolateral prefrontal cortex is involved in signaling these APA errors. So knowing these both motor and cognitive impairments, the objective of this study was to investigate the supplementary motor area and the dorsolateral prefrontal cortex activity during cognitive conflictual steps in individuals with Parkinson's disease, compare individuals with freeze-off gait and those without freeze-off gait. So to do that, we collected 33 individuals with Parkinson's disease, 15 presented freeze-off gait, and 18 without freeze-off gait. So the tests involved two conditions. Could be the congruent tests when we presented like they have to target the arrow in the center of the screen, and based on the directions where the arrow points, they have to step with the right or left side. So the congruent conditions is when the arrow in the middle of in the center of the screen is points the same direction to all other arrows, and the incongruent task is where the arrow in the center of the screen is points to the opposite directions of the all arrows. So basically, each individual had to target the arrow in the center and decide which leg they're supposed to start the first step. And during the task, these arrows in the center, they were not highlighted in red as I show here. So during the step initiation tasks, we collect both the F-nears to see the oxyhemoglobin and the oxyhemoglobin for the activity of the dorsolateral prefrontal cortex and the supplementary motor areas. And also we collect the biomechanic data. So we use force plates, and to see the anticipatory posture adjustment, we also put two retroreflective markers on the both malleolus to see the movement of this APA. So basically during the task, each participant was asked to stand still on the force plates. First, a white screen was showed. This is just to initiate the task and to relax the patients, the participants. And after that, a dot black was showing in the middle of the screen. That's for a preparation tasks. And after that, we show either the cognitive or the congruent or the incongruent tasks. And then the participant needs to decide if they're going to start with the right or with the left side. For the results, we found differences between the tasks for the incongruent and the congruent tasks. So we saw that the anticipatory posture adjustments increase the amplitude, the duration, the delay, and also the task error rates. And we found interactions difference only for the task errors, where the individuals with freeze of gait doing the incongruent tasks, they showed higher errors compared with the individuals in the incongruent tasks, and also compared with individuals without freeze of gait in both congruent and incongruent tasks. For the cognitive variables, we only found differences for the groups between the people with freeze of gait and people without freeze of gait. So we found differences only in the incongruent conditions. We found a lower supplementary motor area activation, and on the other hand, we found that the dorsolateral prefrontal cortex increased following this cognitive task. So in conclusion, we found a reduced supplementary motor activity and impaired anticipatory posture adjustment underscore the physiological basis of the cognitive motor conflict. And for the clinical interventions, we should integrate cognitive process and motor preparation to effectively reduce the freeze of gait episodes and improve the gait stability.
Okay, thank you very much, Claudiane. We do have a question for you that can still be answered within time. And that is a question from Yorick Nonnicus. He says, thank you. Were the freezes and non-freezes comparable in terms of disease severity? And he points to the MDS-UPDRS. In other words, are the differences a reflection of freezing or perhaps of disease severity in general?
Okay, yeah, sorry, I forgot to put these clinical variables, but yeah, we saw that the UPDRS was not statistical difference between groups, so they're really like comparable. So we found also the Horn-Linear was not difference, so we believe this was like more related to the freeze of gait episodes than like the severity of the disease.
Yes, and very importantly, Claudiane, were the MOCA scores also, or MMSE scores, I don't know, your cognitive parameters, were they also similar between groups?
Yeah, they were, yeah. Sorry, yeah, I forgot to put this in my presentation.
That's okay, yeah. All right, can I just thank the 5 presenters for their very interesting talks? Yes, we should have all these applauding hands now on the screen.